Medicare, as you know, there are 4 of them. People don't know that either. They think Medicare is free. They don't know that they have to pay the government to be on Part B of Medicare. Plus, they don't know that they have to buy another plan. So we do help them with all of that and with the options that they have. So usually people in my field are selling more than one plan, and we help them with that in each state that they're in. Part D, a lot of confusion, you know, all the steps, the donut hole, what's it mean, why is it there, it's so confusing, and you know, how can they get around it? There are a lot of ways where you can buy drugs if they're in the donut hole that are less expensive than buying them through your plan. There are no coupons for people on Medicare. Many people are used to getting their prescriptions with a coupon, especially with the high deductible plans, and it says right on the coupon in like 0.4 font, if you are on Medicare, you can't use the coupon. And indeed, they go to the drugstore thinking they can use the coupon, and the pharmacist says, no, you can't because you're on Medicare. Agents do wish that there was a dedicated line at CMS. If an agent does, there's some very unbelievable intricacies in Medicare. And if you, not only is CMS, but it's also the IRS and the Department of Labor. If people really don't know where to get the answers, where do they go? Or they're just going to give them the wrong answer. So hopefully, if they are part of NAHU, we'll have the answer for them. If we don't, we'll get it for them. But there are agents out there that don't belong to anything, and where do they go to get the answers? So that's one of our wishes. So here are the HSA rules and COBRA. A lot of people don't know if you are on HSA, you can't go on Part A of Medicare, and they are on it. They get penalized when they do go on Medicare A and B, let's say if they retire. And there are people that have had some couple $1,000s in penalties. So it gets very tricky with this. A lot of brokers that sell the under 65 group plans don't know these regulations. The COBRA, we have a bipartisan bill, and we hope that any congressmen, people here, and staff would want to sign on for this. A lot of confusion over COBRA and what to do. If I'm 65 and I'm on COBRA, what happens to me? It's different if you're 65 before you go on COBRA. It's also right now, if you go on COBRA and people don't know that Medicare pays first under COBRA. People don't know that, they get in a lot of trouble because they are going to end up paying 20% of their bill and the deductibles if there are any. So the bill is that we would like COBRA to be not have the regulations that are in it now, so that a person that's on COBRA can stay on it if they want to and not be penalized for going on Medicare after they're on COBRA. There are a lot of reasons why people need to be on COBRA when they're over 65, and a lot of it is about they're very sick, and it's actually cheaper sometimes for them to be on COBRA. It's mainly around their prescriptions, but I have figured it out with people. They've had to go on Medicare because the bill, it doesn't exist yet, or the passing of it, but they are spending more money when they're on Medicare when they could be on COBRA and not have that. So with that, that's it for me. Thank you very much.
Batting cleanup. How's everyone doing? You hanging in there? Yeah, all right. So my name is Joel White. I'm the president of the Council for Affordable Health Coverage. We run a campaign called Clear Choices. Clear Choices is our campaign on healthcare transparency, and we've been doing a lot of work, not just on prices and on quality, but also on how folks select plans, the type of information that's presented to them, and what that means in terms of translating cost savings into affordability for consumers. And so we are a very diverse organization. These are some of our members, but we're our primary group of members are employers. We also have payers and healthcare providers, a number of patient groups, biopharmaceutical manufacturers, and tech companies who all came together around one core proposition that we could do a better job pursuing policies that make health coverage more affordable. And so why is that important? What's at stake? And I'll learn how to use this thing, I promise. Why is it important? What's at stake here? Why do we need transparency? And the answer is there's a lot at stake. We see three primary problems in healthcare around transparency. The first is there's really information disconnect. The second is we don't have consumers who are empowered. And the third is we see a lot of data hoarding or people holding on to information that they could share that would make the health system work better for consumers. And this lack of transparency is leading to high health costs. Don Berwick, who was the head of CMS a while ago, said about 84 to 174 billion every year in wasteful spending because we lack good transparency in the health system. Even today, that's a lot of money. I was told to pause to wait for laughter on that one. Guess not. Yeah, I guess trillions now, I guess, I don't know. But it's important because of the relatives at stake here. So we have growing costs in this country. Costs, in fact, are growing a lot faster than incomes. And so the total cost of coverage today for a typical family of four is about 34% of that family's income. Okay? By 2030, that number will be 54%. They'll spend more than half of their income on health care. That's not sustainable, it's not a good outcome, and it's a problem. The second issue is we're shifting a lot of these costs onto consumers. So we see higher deductibles in the marketplace, we see a lot of higher cost sharing, and we also see significant variation in costs. We see MRIs, for example, that could range in one health market from $500 to $6,000, okay? Lots of variation in price, which makes shopping more important. And the third thing is that a lot of consumers will assume more expensive is better, okay? If I have a really big TV and it's like ultra high definition, which I want to get but my wife won't let me, it's really expensive, right? We assume that that's a better television, right? We have a lot of information on that television. We don't have a lot of information on healthcare providers or plans, but we'll still assume that the higher cost is a better plan or a better provider. They've got better skills or better expertise. And in healthcare, what we see actually, the evidence is the opposite. Lower costs are generally associated with better quality, generally. So the third thing is we're just not being smart. Without good information, consumers are at risk of paying significantly more for lower quality services. And the second thing is that we've got good data, we've got good tools, but generally these data and these tools are used poorly. And the third thing is that we as taxpayers fund trillions of dollars in healthcare, but we demand little transparency in return. So the stakes are high, okay? There's a lot at stake, trillions of dollars at stake over the next 10 years. So the other thing, and this was mentioned, and I got to say thank you to Congresswoman Schwartz. She was fighting for better Medicare when she was up here as a member of Congress, and she's still fighting for better Medicare today. So, and I thank her. We're an ally, actually, of the Better Medicare Alliance, and so they do great work. But she mentioned that right now we've got 10,000 people retiring or going on to the Medicare program every day. Every day. About 80 million people will be Medicare eligible by 2035. That's a lot of people. That's a demographic wave that's kind of hitting us. And we need a good tool to be able to present information to them to help inform them about what their choices are. Because as Nora and others have said, this is confusing stuff, okay? The second thing is people are getting better at using computers. You know, you look at a 65-year-old today, or even an 80-year-old today, they don't look like they did 20 years ago. But more importantly, we assume that they can't use computers or websites, and that ageism is just not factually correct. Lots of older folks are using computers, they're using mobile apps, they're using tools to look up, to shop online, and to enroll in plans. And then the third thing is that I think it's true that Medicare Plan Finder as a comparative shopping tool and an enrollment tool is generally, it could use some improvements. Let's put it that way. but it lacks some key attributes that we see in e-commerce. Anyone here use, we do a lot of surveys here today. I guess I'll do my own. Anyone ever use, like, I don't know, Amazon? Every airline, right? There's lots of these tools out there. We use comparative web tools every day, and there's a lot of experts in e-commerce, and that's important because what we see on Medicare Plan Finder, at least, is that it doesn't have a lot of throughput. That means it doesn't have a lot of people who are signed up for Part C or D that are using Plan Finder to come onto those programs, okay? Only about 2 million enroll through the website, and that's a very low number considering the enrollment in those programs. So what is Medicare Plan Finder? Again, it's just a comparative tool. It's a website. Go to medicare.gov and have some fun, okay? Put in your zip code and pretend you're a Medicare beneficiary, okay? And figure out what you can figure out about plans in your area. It's intended to provide people with robust sets of information so that they can make informed decisions to enroll in either traditional Medicare, Part C or Part D, and provide information on Medigap and other benefits like low-income assistance and supplemental policies. It can be a powerful tool to present this information, and there's a lot of information on Medicare Plan Finder. And it can also maximize value for consumers if it's used well. If it were better organized, folks like Third Way have estimated that it could save billions of dollars by optimally allowing people to select plans that meet their healthcare needs. So think about this. If you're a diabetic and you need prescription drugs and you pick a plan that has really poor coverage for diabetes drugs, you're going to spend a lot out of pocket. Maybe you'll be non-adherent. Maybe you'll end up with a hospitalization or two. Maybe you'll end up with a foot amputation, or maybe you'll go blind because you selected the wrong plan. That's a real problem, and it's a real situation that I'm talking about. So in fact, there was a study done on this. I'm not sure how they did this study, but I believe them, where some researchers took a look at some of the data and found that, and I'll have to read this off my notes here, sorry. So beneficiaries could have saved an average of 19 to 33% on their Medicare Part D expenses if they had selected a plan that best matched their medical circumstances. So they went back to 2006, and only 11% of beneficiaries were choosing an optimal plan. And that number went down every year since 2006. So why is that? People get inertia bias, right? They sign up for a plan and they stay with a plan. About 90% of all Medicare beneficiaries will stick with their plan. And there's a lot of reasons for that, which we can get into in the Q&A. But the point is if they had better information to say, hey, Plan A is actually a lot better for you, you should switch and you could save a lot of money, we would actually save more as taxpayers and they would save a lot of money as consumers. So we're not being smart about some of this stuff. So we went and took a look at Plan Finder. We said, well, we shouldn't just take our bias. Let's systematically look at it and figure out, is it doing a good job? So we did. And we did that with our allies and colleagues at National Council on Aging over the last 6 months. I don't know. Feels like longer, maybe. I don't know. Anyway, we did 3 things. We evaluated the website across 9 primary categories, and you can see them there. The second thing we did was we, primarily NCOA, sat down with 25 beneficiaries as they were going through Plan Finder to help assess their real-time experience. And the third thing they did was they sent a survey to every SHIP in the country and said, what do you guys think? And again, I want to be cautious because we haven't released the report yet. We're releasing it next week. So I'll give you kind of like, I tried to off-center the scorecard and like make it small so you couldn't read it and all this other stuff. But basically what we found was that when we release this report next week, you'll get the details on this. But Plan Finder got A's for 2 categories, anonymous browsing and their non-English translation services. Primarily in 7 other categories, they got D's and F's. So mostly failing grades. What is that? You guys don't know what that means. What it means is when you go on Plan Finder, what you'll find is a website that's full of insurance jargon. It's confusing. The layout is presented in ways that don't allow you to make readily intuitive comparisons. The cost information on both premiums and cost sharing is very hard to understand. And we talked about doctors and PhDs from Harvard. I have a GED. I find it confusing. Well, I thought that one would have gotten a man, tough crowd. It's a tough crowd. The other thing is hard to use. To do a drug comparison, you've got to know what drugs you're on and what milligrams you're taking. So I take Prevacid, okay, for reflux disease. And I don't know if I'm on 15 or 30. I had to look it up. I was online last night using the Plan Finder thing. And hey, I'm on 30 milligrams. Great. Now you know some HIPAA-related information about me. But beneficiaries have to know that, and a lot of times they don't. What we know about Medicare beneficiaries is they don't know what drugs they're on or the milligrams that they're on. So it's hard to enter that information in and to make some accurate comparisons. So we see some challenges with Medicare Plan Finder. What we know is as this demographic wave comes through, that is going to be really important for an online tool to be really super optimal and helpful for consumers to sign up for a plan. And it's not right now. So what should we do about it? Should we take the website down? No. We can do a couple of things. We can either improve Medicare Plan Finder. I think we should. We make 11 specific recommendations in the report we'll release next week on how to improve it, how to make that information easy to compare, fruitful and useful for consumers to choose an optimal plan. Because remember, people can save a lot of money, but so can taxpayers. The second thing is that's going to cost money, okay? And how many members of Congress are just itching to spend money on a website that the federal government runs? I don't know, call it the opioid website or something. So Congress should fund the improvements because it does have an impact on taxpayer costs, okay? And because those subsidies are tied to optimal plan choices. And then the third thing is, and it's an open question, it's a question I think we ought to be asking. I'm not here to advocate at this point, but I'm asking the question, and that is, with all the tools that we see in the private sector, Amazon, American Airlines, eHealth, Health Sherpa, healthcare.com, and healthcare.gov, I guess. Should we consider farming those functions out to the private sector? Where maybe they're more sophisticated, they can maybe do a better job and have some competition. I'm not sure that we're at an answer yet from our standpoint as an organization. I know in the report we don't specifically say one way or the other. But these are three options, or three things that Congress and the administration could start doing to improve the Plan Finder, not as a goal in and of itself, but to improve the shopping and enrollment experience so that we can save some money. Thank you.
All right. Thank you, Joel. We actually have several questions here, so I'm going to run through them as quickly as we can. One question for the panel is regarding communicating with Medicare-eligible beneficiaries earlier than 65. Is there agreement amongst you that that would help clarify some of the confusion? And if so, how early should we begin communicating? You want to take that? Sure. Yes, if you press the button.
So I usually talk to people 3 or 4 months before they're turning 65. I do talk to some people because there are people that, as you know, they have different personalities. They want to know everything as fast as they can, as soon as they can. But if I talk to them a year out, the information's going to change, which I tell them, and the premiums, the plans, I mean, everything could change, but at least I can give them an overview of Medicare, but they're not going to retain it all because, as we know, we all have ADD in some regard, and they're only going to get a little bit. So I try to make the information a year out to be as simple as possible, and that's really just not even going through the plans, but just A, B, C, and D, this is how much it might cost you, and, you know, you could have these options. But they just won't remember it if you do it too early.
Oh, okay. It was light push, not a heavy push. Okay. So we call it just-in-time education. Most people won't seek out information until they need it, so it's just in time. However, we would also agree with what was just said with the from our standpoint that 3, 4, 5 months is probably about the amount of time that you need to prepare for this. There's a lot of things to consider. If they haven't been tracking their medical records or expenses, gathering it, putting it all together, looking at how their situation will change. But realistically, there will always be a need and a demand for this just-in-time education.
2 seconds, just to advocate on behalf of women, because when I saw when I was at ARP and also just knowing, a lot of people don't understand that spouses aren't covered under Medicare. And so there's a phenomenon that a lot of men become 65 before their wives, and then they don't realize they don't have coverage. So the more that you all can help share that type of information, it's really critical. It's not just a women's issue, but more likely to be.
Okay. And a question for Joel. You mentioned that people tend to stay in their plans year to year. Is there any insights as to why that might be? Is it because of confusion of picking a new plan? Why doesn't it get easier for Medicare beneficiaries as they age into the program?
This is a really good question. What we know is that about 90% of people stay with their plan over time. That's true over time. And I think part of it is preferring inertia over change, or the status quo over change. Part of it also is, I think, this confusion about what are my options. And so, again, you go on the Medicare Plan Finder, it is one of the things we looked at in the report was, can you do an apples-to-apples comparison between fee-for-service and Medicare Advantage, or Part D, or fee-for-service plus Part D and Medicare Advantage with an MAPD plan? And the answer is not easily, or not, no, basically. And how you get there is going to be really, really difficult. But that's something that we hear from a lot of beneficiaries is, I want to know, if I stay in fee-for-service, am I going to save more money versus going into an MAPD plan? And that information is just generally not easily accessible on the MPF. So when you're faced with no clear answer, you tend to stick with where you are. And then the third thing I would say is that maybe demographically, risk aversion probably sets in, and so if you don't understand your options and you're unwilling to reach out to a SHIP or an agent or someone else to help get the help, then you won't.
The question for Dr. Brown actually is, extending from that, if did you see in your Smart Choice program results that show that perhaps seniors who were engaged early on in the initial decision making, did they continue to make active choices afterwards?
So I can speak more to the Smart Choice. I have to be fuzzy on the Smart Use since we're still looking at all that data. But yeah, we are seeing that if they leave with the skills to apply the knowledge, and we give them a budget, we give them a case study, we give them a comparison tool to compare apples to apples or apples to oranges they're better able to take it home and use it. So for the choice, it does seem to be working, that they're giving these tools and they're giving our information to call us in case you get home and forget, like I sometimes do. With use, we're trying to pair that right now when we're looking to doing a study about the continuum of from choice to use and whether or not that information flows through and dose response. But we are finding that with Smart Use, Smart Actions as a standalone, people are able to use that in their lives a little better. But we haven't connected those two yet with a study.
Okay, and this is an easy question for Nora. Question from the audience: if you're still working at age 65, are you still required to enroll in Medicare Part A?
Oh, that's a question people get all the time. And if you have employer coverage if you're still working and you have employer coverage, then Medicare becomes a secondary payer
Could I say something about that too?
Yes.
If a person is still working, if a person is still working and there are more than 20 employees in the company, they don't have to go on A and B of Medicare. If they're on an HSA, there are other regulations that they should, if they need to stay on it, they shouldn't go on A and B of Medicare. And if they're under 20 employees, they do have to go under A and B of Medicare because Medicare pays all your claims first if they're under 20 employees.
So you can certainly clarify, but there is
Not if they're over 20 employees, though.
existing.
If you have employer coverage, you don't need to pay for Part B, but if you. Rest of your life, pretty dramatic penalty. We actually, in the report, talked about this a little bit, is that HR departments in employers should know about this answer, and they don't. And actually, at the convening, one of the other experts had a great story of saying he's an expert, he turned 65, he's still working, he didn't begin to do anything. And he went to the HR department, he said, I have no clue. And so he had to try and figure that out. And the answer, you can see we're having a little bit of a discussion even here. It is really confusing for people who are working, and more 65-year-olds are still working. So it's not an unusual situation.
But some, it depends, that's why you have to, it depends on your employer, because some employers will make you go into A and B, but reduce your health insurance costs to recognize that. So you really have to be very employer specific as to whether your employer then wants you to go into what they call a carve out, which takes care of people who have A and B, and then they'll reduce your regular premium. So you really have to check with your employer as to what the arrangements are.
Well, if it's over 20 employees, it's against the law for them to tell their employees to go on Medicare. They can do it under the table, but it's against the law.
Well, as you can see, there's already a debate over this, so it goes to the point that we've been making all day today about how difficult this is to navigate. But I'm going to save one more question, and which is multi-tiered here. But again, to the complexity of Medicare, the question that I have here is, does it help insurance providers to have this complexity exist in Medicare, because does it lead to consumers choosing more expensive plans and ultimately making more profits for them? I think Joel touched upon this a little bit earlier, that ultimately all these people here, as you can see, we're all here for the same reasons, and that is because the complexity of Medicare doesn't help anyone, right? And so ultimately, what we're trying to do here is, it doesn't help an insurance provider if someone doesn't stay in their plan because it wasn't the right plan for them. It doesn't help an insurance provider if they report low satisfaction with their plan because it wasn't the right choice for them. But as far as the complexity of Medicare, I wanted to invite the Congresswoman to talk a little bit more about how the recent policy changes with Medicare Advantage contribute to this conversation.
I'm happy to try and tackle the tough, the question just broadly, and that is, we certainly feel strongly that simplifying this and making the information more comparable is really just extremely important. It's why we're here. So you're exactly right. It's what, even at the slightly different perspectives, which there weren't much, but it really is a question about how can you get this information and to beneficiaries so they can make the best choice for themselves. We work with plans, they agree, and there are 2 points here, is that there's a certain standardization, which is actually helpful. Like all the benefits under Part A and B have to be provided by Medicare Advantage. So that is a starting point that every beneficiary can feel reassured about. I'm not giving up any benefits if I actually choose Medicare Advantage. However, there's increasing understanding that some flexibility, some ability of plans to tailor benefits, including things that really benefit beneficiaries, and tailor benefits that include extra benefits for everyone, but might also include extra benefits for those who have serious chronic conditions, for example. And CMS and Congress both recently are giving plans that opportunity to tailor benefits. I'll give an example. If you're a diabetic and you have copays, but that copay inhibits you from, because of your low income, not dramatically low income, you're above that, inhibits you from actually paying that copay when you go see the podiatrist. That's not helpful to anyone. It's not helpful to the individual person who might actually not go to the doctor and not go get foot care. So there's some interest in what if we actually just made that visit to the podiatrist no copay. But, same thing, you can use every chronic condition for an example of making sure that you engage with your clinician, preferably with the most appropriate clinician in the most affordable place. Then that helps everyone. And the plans agree, they want to do this, and when you're in a capitated system for the plans and the providers who take risk, it changes the incentive from a fee-for-service system, which really can be very fragmented. You can duplicate or overutilize services, but to one that actually has an incentive to make sure that you get the right care at the right time in the right place. That sounds a little bit too wonderful to believe, but in fact, there is really a lot of understanding now that having a primary care physician, clinician, could be a nurse practitioner, having easy access to outpatient services, or being able to call and interact, or email and interact with a provider, being able to get fitness classes that help you move and can reduce all sorts of chronic conditions. All of these things that's seen as like, aren't those extras? The fact is that they have a direct impact on patients' ability to comply with clinical protocols to actually improve outcomes. So those findings are not insignificant, and to give a part of Medicare the chance to really address these needs, because it's been tough for Medicare to say, okay, we're going to add this for everyone. They have recently done that. We hope that some of the learnings from Medicare Advantage might actually do that. For example, the Diabetes Prevention Program, that was the first prevention program that really is reimbursed by under CMS, under Medicare. That's kind of a big deal. It turns out there are not enough providers right now to fill all the needs, so that's kind of interesting. Not a surprise by any means, but it is really an opportunity for the plans and the providers who are increasingly working together to share data on who are the high-risk patients. All of these things are actually involve costs and investments, but actually will save money. So I think the incentives are aligning in fact, the right way. And I know there's some people who object to the idea of insurance companies in principle, but in fact, they're really a mechanism for managing these costs and getting people and working with providers to get people the care that they need. Is it universally wonderful? I'd like to think so, but there probably is some unevenness out there. But honestly, there's unevenness in Medicare fee-for-service as well. So our goal is to actually improve that quality, to let people know about that quality as well, and let them know about the additional benefits and potential opportunities that might work for more people on Medicare.
So we are actually over time, but if you did have additional questions after this, please just see one of us. We would love to still collect your questions and just get back to you. We can collect your contact information. Also, there are evaluation forms in your packets and on your chairs. If you could fill them out, we would really love to get that feedback. And we really appreciate you coming here today. Please visit our website, bettermedicarealliance.org, to view the Medicare Advantage enrollment map by district, to see if your members on our Congressional Appreciation page. Please try to attend the Medicare Advantage Summit and Conference. It's really wonderful. It's basically all the major thought leaders from across the country. We have United Healthcare CEO Steve Nelson as the keynote. So we really invite you to come and attend because it's free for staffers. And a lot of people are fighting over those tickets, so it's free for you guys. But anyway, we really appreciate you guys coming here today, and we really appreciate all the speakers making yourselves available today. You were really wonderful. Thank you so much. Anything on there, that's